Hi, this is Brian Kim. I'm going to share with you case number 119 in the best way to do cataract surgery series. This is a patient with a very large, giant-sized pupil, and this will be a beautiful anatomy showing double chop, cross chop, and mechanical fracturing. You'll be able to see placement of the chopper and the movements that I make. All of the maneuvers are centripetal, meaning they're forces that are directed towards the center. This is very zonular friendly, and if it's executed correctly, there's no tilting of the lens, there's no downward force on the lens. And so again, very safe on the zonules, minimal trauma and stress on the zonules, and you'll be able to see very clearly the placement of the instruments during the chop maneuvers. So I'm using a cotton tip to steady the eye, and then using a corneal marker, which will help me to center and size the rhexis. And then I'm making my paracentesis incisions, first on the right side and then the left side, making sure the incision is parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral lidocaine, and then some intracameral epinephrine, and then some dispersive viscoelastic. You can see how beautifully huge this pupil is. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, flatten out, tunnel, and then lift, and then enter. And this is a triplanar corneal incision. And this is the Haldey-Perkar cross-section forceps. You can see the forceps are designed slightly differently. Instead of forceps that are side to side like tongs, they're sideways like scissors. So go ahead and very carefully try to puncture the center, which I'm able to do. And then I'm able to grab the tear to create a flap. Because it's a very large pupil, the temptation is to make the rhexis larger than you really want to. And so that's why that corneal mark is quite helpful. And the secondary cue is you see that little hash on the forceps, and it tells you that's, I think, a 6mm marker there. So I'm going around circumferentially. You can see how well controlled the rhexis is. I'm not having to pull centrally. It doesn't want to radialize here. Very well controlled, very minimal wound gape, very minimal viscoelastic egress with the rhexis. Go ahead and finish off the rhexis. Burp some viscoelastic out. And this is the Capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, come out and decompress on the left side, point the tip down, and the lens begins to spin, hooking it on the right side. I tried to do a hydro delineation. It didn't quite work. So go ahead and irrigate the surface of the cornea here. Lift the incision with the chopper. Go in with irrigation off, minimizing Decimase trauma, removing the surface epinuclear material. So I want you to pay attention to the double chop maneuver. There's minimal tilting or pushing down. I place the chopper around the lens with the chopper, tilting the defecative vertically subincisionally, and the lens fractures really nicely. Placing the chopper around the right heminucleus, pulling it centrally, which crushes the lens against the ficotip, and it divides the right heminucleus. Using a vacuum to lift that first quadrant up, crushing the lens between the instruments, and then emulsifying the lens piece. As you can see, I'm placing the chopper at the level, the interface between the epi and endonucleus. So I don't really have to place the chopper all the way out to the capsule. Really, I just have to chop the endonucleus. And so that's why it's even safer than you really think. Again, you're placing the chopper around the endonucleus here, placing it down, pulling it centrally towards the ficotip, and then crushing and bisecting that second heminucleus, and then using some vacuum to grab that third quadrant, and then crushing the pieces into smaller pieces, and then emulsifying the lens piece. By using crushing forces, you're able to make these pieces smaller, thereby utilizing less ultrasonic energy. Grabbing the epinucleus on the anterior side, which causes it to tumble out, and I'm keeping the chopper deep as I do this to protect the posterior capsule. take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I always start subincisionally, removing the cortical material in the subincisional space from anterior to posterior. My rationale is the cortex is creating a buffer cushioning my IA tip from the posterior capsule, and it keeps the posterior capsule concave, and so I'm able to remove the cortex confidently. Go ahead and switch to polish mode, polishing under the rhexis edge, removing the lens epithelial cells, and the INA does a really nice job in polish mode because the aspiration and vacuum are very minimal. It's not going to cause any traction or stress and damage of the zonules when you do this, and you can also polish the posterior capsule surface with this maneuver, which is really quite helpful. The polymer tip is really very safe, and I've not ever had any trouble causing posterior capsule rupture or any damage to the posterior capsule doing this maneuver with the polymer tip. Pulsing BSS into subincisional capsule fornix, and then I'm going to go ahead and inject some cohesive viscoelastic to fill the capsular bag. And then I'm going to go ahead and sweep. Again, this is my original sweeper that I'm using. You can see the head of it is, the paddle is smaller. And again, the paddle, the anterior edge is not as sharp. But because the pupil is so big, you can see how much lens epithelial cells are being liberated with this maneuver. Go ahead and place the single piece acrylic lens into the capsular bag. I try not to come in and out of the eye unnecessarily and try to use the same instruments for a variety of parts of the surgery here. So once the lens is going in, I quickly transition to the INA tip, making sure both haptics go within the bag. Tilt and go underneath the optic, tilting it and rotating at 90 degrees clockwise, removing the viscoelastic from within the bag, polishing under the rhexis edge as well, making sure all those lens epithelial cells are gone, rotating the lens just a little bit, making sure all the lens epithelial cells and any minimal cortex is removed. Switch to visco mode, removing the viscoelastic from the anterior chamber, and then I'll hydrate my incisions. So you can see this is a really giant pupil. It really illustrates the technique, and you can see everything very clearly. Again, with the double chop, cross chop, the forces are horizontal, and so there's a crushing force. There are opposing forces from either side, using the instruments to crush the lens from either side. With horizontal chop, you have to lollipop the lens. You're only crushing it and scoring it from the top. With vertical chop, you can't really do this on a soft lens. It'll just cheese wire. And if it's overly dense, you can't really do it as well because it can't fracture through a posterior plate. And divide and conquer, of course, you have to sculpt, which causes a lot of zonular stress as you're pushing down. And so this technique is really minimal zonular stress. There's no sculpting. You don't have to lollipop the lens. You're getting around the girth of the lens. You're getting the instruments around the lens and crushing it. So you get a deeper chop and therefore more effective chop. And so I really feel like this is why, in my opinion, this is the best way to do cataract surgery. So I hope this was helpful to you, and I thank you for your attention.